All right, so now we're moving on into our chapter of pediatric gastroenterological diseases. We just finished looking at a bunch of our topics for cardiovascular things that happen in pediatrics. Infinite things over there. I mean, thankfully, they were all topics that were step one related, but it's very in depth. There's a lot happening with very distinct heart sound choices or murmurs that can occur in the question stem, and then based off of that, you have to identify whether it's a VSD, ASD, and stuff like that. So that chapter in the pediatrics aspect, the cardiovascular chapter in the pediatrics aspect, is difficult until you have revised it enough times. You got to be very comfortable with exactly the dynamics of what is happening with each and every single one of these defects. You should know these flow arrows because they determine what sounds you're going to hear. The flow arrows also determine where oxygenated blood is going and where deoxygenated blood is going. And then of course the other factor that we spoke about were questions where they give you oxygen saturation. They might tell you like oxygen saturation in that area, oxygen saturation here, here, and here. So these four places, if you look at it, they should have the same exact oxygen saturation. If blood coming from the superior vena cava and the inferior vena cava, right, both of those areas, the blood coming back, they should have relatively same amounts of oxygen saturation because the superior vena cava stuff was all blood that has been drained of oxygen by the brain and arms, and inferior vena cava is blood that's been drained of oxygen from the legs, right? So all of that, maybe these two places are going to have a value of x equals, let's say, like 20%, oxygen saturation of 20%. Then if oxygen saturation is 20% in there, then when the blood arrives at the right atrium, it should also still be 20% oxygen saturation. That's going to go into the right ventricle, still should be 20%, right? Because none of these are places where they're going to pick up new oxygen, right? They can lose a little bit of oxygen, but not gain oxygen. There's no reason for anywhere here to be gaining an oxygen, unless there's some kind of mixing where maybe blood is flowing from the ASD into here, then oxygen saturation would be increased in the right atrium. Or if there's a VSD where blood is flowing from the left ventricle into here, then oxygen saturation would randomly increase in the right ventricle, right? So those are some key things to watch out for. There can also be a scenario where oxygen saturation randomly increases in here, in the pulmonary trunk. That would happen because there may be a connection between the aorta and the pulmonary trunk, which would be the the patent ductal arteriosus, like that, right there. Right, so oxygen saturation questions are somewhat difficult. The other set of questions are just about what kind of heart sound you hear, which is really talked about a lot, especially in this page where they did the whole VSD versus ASD thing. Right, you have to pay attention to the fact that an ASD would have fixed splitting, and it's going to be a systolic murmur with a mid-diastolic rumble at the left lower sternal border. Right, so that's exactly what you're going to hear. Now, not all of that may be given to you, but the bits and parts they do give you, you have to catch correctly. And you have to make sure that they're saying mid-diastolic rumble at the left lower sternal border, not just any other kind of murmur at the sternal border. And you have to be able to compare that to what you hear here, which is a holosystolic murmur, right, with a mid-diastolic murmur at the apex, right, mid-diastolic rumble at the apex, which is also roughly in the left lower sternal border. So we talked about all of that. We got it all down. Make sure you keep revising it. It should stick to you. And then when you do questions, it should all come back to you. And you should be able to figure out exactly what's wrong with the patient and what needs to be done to keep them going or to make them feel better. Now we're looking at GIT. So first thing is your notorious topic of pyloric stenosis, which we looked at in step one. Okay, so step one, that was our grandiose question with the the olive-shaped palpable mass at the pyloric area, right? So most common cause of gastric outlet obstruction in infants, palpable olive-shaped mass, right, which is all muscle in the epigastric region, visible peristaltic waves, and non-bilious projectile vomiting at about 2 to 6 weeks old of age, right? So this is going to be non-bilious because remember, bile mixes in the duodenum. So food has only arrived down the esophagus into the stomach and then is unable to really pass into the duodenum. So no bile is mixing into it. So a question doesn't really need to give you much. If they just tell you that a child who was born, they give you a long history of how the baby was born, how the mom's prenatal course was, etc., and then they'll be like, the child's been doing fine, but now all of a sudden the child is just vomiting every day and it's non-bilious vomiting. What's wrong? They don't need to give you anything else. So then A baby will only really have non-bilious vomiting for one of two reasons. We looked at this. One was the previous thing we looked at, which is this, right? If they have esophageal atresia, food will come into here, and then it can't even reach the stomach, so it just comes back out. And of course, there's no bile there yet. And then this is case number 2, where the food comes to the stomach, but then can't go to the duodenum, so again, there's no bile, and it comes back out. The two case scenarios are very different from each other, though, because there's always going to be these connections that are also going to give the baby some cyanosis and choking spells, because the trachea and your esophagus should never have any connection to them, right? So esophageal atresia is one of those other case scenarios where a baby would be vomiting non-bilious food. You can do an ultrasound and you're going to see it. When you do the ultrasound, you're going to see exactly what they're showing you here, that this muscle mass is really thick, and in the middle, the channel is really thin. Right, so that's what they're showing you. Now, what would really help is, of course, looking up an image of what a normal ultrasound would look like. So let me see if I can find that. Normal ultrasound for pyloric, or pylorus in general, actually. Yeah, pylorus. Let's see what we find here. You know, when you start looking at these images in on Google, when you start searching these things up, and you start actually looking at so many more ultrasounds than you've ever probably really looked at, you start realizing that you have no idea what the heck you're looking at. And the more you practice, the better you get. I'm seeing a bunch of ultrasound images on Google right now when I search for normal ultrasound for pylorus, but I can't really tell any image that I see that looks normal. Most of these actually are for pylorus stenosis. I'm not really seeing a normal ultrasound of, yeah, every single one of these is hypertrophic pylorus stenosis. Even though I put normal, let me put normal pylorus maybe. Yeah, nope, not seeing one. Okay. Well, I guess if anything, you're not really gonna need to know what the normal one looks like, as long as you know they're giving you an ultrasound of some part of the stomach, and the question is about non-bilious vomiting. Then it should make sense to you that that question must be a question about hypertrophic pylorus stenosis, right? Now, one of the other things that you often get tested on are the electrolyte abnormalities that generally occur with vomiting, right? So that's going to be one of those things that are your acid-based questions. So of course, you're going to have hypokalemic, hypochloremic metabolic alkalosis. First of all, it's very obvious you're going to have metabolic alkalosis, because the question is always about vomiting, and vomiting gets you to lose all your acid. So that's obviously going to cause alkalosis, right? And it's not respiratory, because this is based off of your metabolic engine, right? Whether you're eating or not. So respiratory things is all about this pace of respiration. Here we're looking at the food intake, or diarrhea versus vomiting kind of difference. So hypokalemic. Now, why hypokalemic, hypochloremic? So give me 1 second. Let me just see something my mom's saying something. Alright. So here I explain why that happens. So the vomiting causes, of course, a loss of acid. And when you lose ACL, basically you're losing not just the acid, but also the chloride, right? So you get hypochloremia. And then to compensate for this, renal compensation for this H loss, right? So your stomach is losing the chloride, and you're also generally losing H plus, which is the actual acid in your system. So for this H plus loss, your body's going to try to preserve protons at the expense of potassium. Right? So instead of tossing out H plus, your kidney is going to toss out K plus. Right? There is a need to toss out H plus because of an exchange that occurs in the body, but that exchange is no longer going to be handled by exchanging H plus. Instead of doing that, you'll just exchange it with K plus, so you could save some of your H plus. So you end up losing chloride and potassium. As the disease is named, the red arrow in the image of the stomach over here is showing you the smooth muscle hypertrophy of the pylorus muscularis mucosa, forming the olive-shaped mass felt on palpation. This is a metabolic alkalosis because without chloride, the basolateral bicarb chloride exchanger of your PCT will not work. Okay, now I'm getting a call from my sister. Yeah, I'm not. I was gonna leave later, but you could just take it if there's nothing else. Just I'm teaching right now, so just take the key. Mom's downstairs. Oh, okay, okay. No, no, thanks, thanks. Yeah, that's fine. I'm gonna be leaving again. All right, bye. All right, so that takes care of all that stuff, right? You got to make sure you know this event that occurs with the electrolyte abnormality. It should make sense to you, and they love testing you with the electrolyte questions. They always throw in these random questions where they're gonna have the up and down arrows, right? So they'll list out like Na, Cl, K, H, bicarb, right? And then you know that this is obviously causing vomit, right? So when you're vomiting, you're gonna lose chloride, and obviously you're gonna lose H plus. Now, as you lose H plus, your body tries to save you from losing too much H plus by throwing out some potassium instead. So you end up losing potassium as well, and you're also going to try to retain. Sorry, right now, because of the loss of the acidosis, they have alkalosis now, right? Because you lost H plus. So if you lost H plus and you have alkalosis, your bicarb will normally just stay the same. Remember, bicarb changes require renal changes, and your kidney doesn't really change anything that quickly. Your kidney is a very slow responder in changing anything. That's why any metabolic compensation usually takes time, whereas respiratory compensation is quick. So there will actually be, for this metabolic alkalosis, right now we have metabolic alkalosis because we lost our acid in a metabolic way. Um, to fix this metabolic alkalosis, you're going to need respiratory compensation. So there's just going to be some rapid breathing that will occur, but since this is a newborn, that's not really a major scenario here. Kids are always breathing fast as it is to begin with, so it's not really something that may or may not be on the chart. Point is, you should be able to fill all of this out. There's going to be breathing rate and whatnot, everything on this table. It should logically come down to something you can fill out. Acid-based questions are one of the top few topics that are very difficult for STEP students, so make sure you've got it down pretty well. Here they're showing you another ultrasound. I actually saw something similar to this when I googled normal ultrasound for pylorus. So there was a lot of them had GB written in them, and I wasn't sure what they were talking about, but now I see it. So GB is your gallbladder here, right? And then the L they're telling you is your liver. And right here you're seeing, let me see, is this a normal one? Schematic representation of a hypertrophied pylorus, which is a cartoon image. The arrow denotes protrusion of the pylorus into the duodenum. Okay. I see what they're talking about. All right, so they go on to say longitudinal in ultrasound B, longitudinal ultrasound of the pylorus showing a thickened pyloric musculature, which is the X's. Right, so from here to here, you can see this is a very thick muscle. Right, and then over a long pyloric channel, which are denoted by the plus sign. So this is your pyloric channel, and it's a little slimmer than it should be. And that's all that's really happening here. But again, you don't need to fully understand ultrasounds as long as you know that the child has a symptom of non-bilious vomiting, and they're giving you an ultrasound of the stomach area like this. Then always remember the gallbladder is that thing with the black shadow to it. It's not really gonna reflect anything because it's just a gallbladder. It's empty. It's got some fluid inside. It's not a solid thing like this. Like the rest of everything. So yeah, they're just showing you the pyloric stenosis, of course. This is a way for them to show you the pyloric stenosis rather than telling you they feel a olive-shaped muscular mass in the epigastric area. Right? So the book tells you hypertrophy of pyloric sphincter leading to gastric outlet obstruction, more common in firstborn infant boys, associated with tracheoesophageal fistula, formula feeding, and maternal erythromycin ingestion. Maternal erythromycin ingestion is somehow randomly a part of this. It's always been mentioned, even in step one. I've never seen a question where this was actually asked though. Non-bilious emesis typically begins around 3 to 5 weeks of age and progresses to projectile emesis after most or all feedings. Infants are generally hungry after episodes of vomiting. They initially feed well, but eventually suffer from dehydration and malnutrition. Exam may reveal a palpable olive-shaped mobile non-tender epigastric mass and visible gastric peristaltic waves. Best initial test is obviously just do an ultrasound. You're going to see the thick muscle and a very elongated and squeezed pylorus. Lab workup reveals hypokalemic metabolic alkalosis because emesis results in ACL loss, and then the renin-angiotensin aldosterone axis will activate and do whatever renin-angiotensin aldosterone always does. So you mainly need to know what aldosterone does, exactly how aldosterone works. For revision purposes, if you ever can't recall all the things that aldosterone does, then you always want to make sure you go back in the step 1 first aid book and come down to here and look at my little perfect way of memorizing it. All right, so here we have adrenal insufficiency, in which you're lacking glucocorticoid and mineralocorticoid formation. So the glucocorticoid formation is obviously just lack of cortisol. That's easy. The lack of aldosterone, which is a mineralocorticoid, is the real thing. So you have to remember, when you don't have aldosterone, you lose sodium and you keep potassium and H plus. If you ever keep H plus, you can't keep HCO3 minus as well. So you lose HCO3. Losing HCO3 means that you're going to keep Cl minus via the basolateral bicarb chloride exchanger found in the PCT. So basically, you think lose sodium HCO3, right, so sodium and bicarb, and keep HKCl, right? This is what happens when there's no aldosterone. When there is aldosterone, it's the opposite way around, right? So you'd be keeping everything you lost here and losing everything you kept here, right? All the lose and keeps would go backwards, because of course when you have aldosterone, you keep sodium, so that means you lose potassium and H plus, and so on and so on, right? So a great thing to always keep coming back to revise. It's a very helpful thing. So here the aldosterone is going to activate. So obviously with all that aldosterone, they're going to retain sodium, which makes sense because they've lost chloride, so they have to do all these changes to make up for the volume loss, right? To maintain blood pressure, because vomiting is also a form of dehydration. Barium studies, if done, will show a narrow pyloric channel, which is the string sign, right? It's literally going to make a string in the pyloric channel because that's how long it is now, as opposed to how long it needed to be. So what I just underlined here, what I just highlighted here, is basically all of this. But it wasn't supposed to be like that. The normal stomach isn't that long of a channel. So that becomes what you're seeing here, and that's what you're going to see on the ultrasound with barium. Treatment is to obviously just keep the patient NPO, so don't make them eat anything by mouth. You would try to do a IV access for food. Correct any dehydration and acid-base electrolyte abnormalities. And the most definitive treatment, of course, is they're going to eventually need surgical removal of some of all this extra muscle here, right? Just get rid of it, and they should be okay. Right, so now that being said, we have a couple things on the left here. We have crying in young infants, differential diagnosis of regurgitation and vomiting in infants, and then food protein induced allergic proctocolitis. So crying in young infants, we saw a question about this regarding, actually we've seen many questions on it, but here you have, the way these URL tables are made is that you can have a question on each one of these things individually, right? Each one of these things is its own topic to have a full question on. A child may have colic 3 or more hours a day, usually evening, 3 or more days a week. Healthy infant with under age 3 months. That is a child with colic that may be crying. Right? GERD. In pediatric GERD is usually very different from adult GERD, but mainly they're going to have frequent spitting up, right? Frequent regurgitation and spitting up, and they're going to have this back arching they do after feeding because they have all this acidity that kind of makes them arch for some reason, and they'll also be crying. Infection, of course, makes them cry, depending on where the infection is. Different symptoms will present. Intussusception is very painful. The target sign that you look for in ultrasound. We saw that in step 1. Torsion, mainly testicular torsion, super painful. It's an emergency. You need to get them surgically corrected really quickly before that testicle or ovary suffers necrosis. And then, of course, any kind of trauma, right? Whether it's abuse, corneal abrasion in the eye, or hair tourniquet, right? Hair accidentally being wrapped around a digit. All kinds of weird things that can occur in young infants. You just have to watch out for it. So of these, probably the most difficult differences are the colic, GERD, and then, of course, now looking at pyloric stenosis. Here they have differential diagnosis for regurgitation and vomiting. So the first one here, GERD, right? So this is a very high-yield topic in the sense that it's something that needs to be caught and fixed in both infants and adults. Otherwise, it can lead to worse problems. So the first thing that you should, if they ever mention in the question that the child is spitting, then the first thing that should come to your mind is GERD, and you should immediately start thinking of that. Right? Physiologic, asymptomatic, happy spitter, and then pathologic issues of GERD are failure to thrive, significantly irritable, and Sandifer syndrome. So now Sandifer syndrome, let me just look it up for you guys real quick. Find a good picture. Oh, this one right here. So this picture will hopefully stick to you. I never forget this. It's kind of creepy, but this is Sandifer syndrome. So they roll their eye. If you look up Sandifer syndrome, all you're gonna see is eye rolling. Right, so a lot of eye rolling is gonna be. This eye rolling thing that they're doing is not nystagmus or anything. This remotely creepy looking event that's occurring right here is due to GERD. Right, so that's part of Sandifer syndrome, and that's something. Let me see if there's a whole thing for Sandifer syndrome. So we have, like, this is another thing here. This is another diagram someone made. Right, expert docs. So you have epigastric discomfort, some non-bilious vomiting, cough from the burning sensation at the end of the esophagus. Of course, sleep disturbance, especially if acid reflux is happening when they're trying to sleep. Poor weight gain because they won't really want to eat. They're going to associate eating and swallowing with acid discomfort. And of course, they can actually choke on it, so it can go into their lungs as well. And here's the abnormal eye movement thing. They call it just abnormal eye movement, but in other places you'll see it's referred to as eye rolling. It's a very weird phenomenon, and it looks really bad on the child too. The child doesn't look good. If you Google images of Sandifer syndrome, it all looks really weird. And they tell you in e-medicine, Medscape, Sandifer syndrome is a condition that involves spasmodic torsional dystonia with arching of the back and rigid opistotonic posturing. So something that would basically be related to like Clostridium. Clostridium tetani, right? It's very similar to having tetanus. The same kind of arching that you would see in tetanus infected babies. That's what you're seeing here. And it's also associated with symptomatic GERD, esophagitis, or a hiatal hernia. Initial treatment consists of lifestyle changes such as dietary modification and positioning. So you got to be careful to understand that if a child is presenting with symptoms that make it look like they have tetanus, right, with the opistotonic posturing and the arching and all that, and their eye motion may be something, I don't think they'll call it nystagmus in the question, but you might think it's nystagmus. All of that together is actually not tetanus at all, because there should be one other symptom of some kind of spitting or failure to thrive, not really absorbing food well, stuff like that. Now, so GERD is a topic that would be considered a pediatric GERD is a topic that would be considered a very hard topic for a pediatric GIT question. You'll have to connect the dots and rule out things that don't make any sense. Milk protein allergy is another thing. We'll see some questions about it. Clinical features are regurgitation, vomiting, eczema, and bloody stools. And they often have other allergy things too. Some other kind of history of other allergies. Elimination of dairy and soy protein from their diet is the easy and obvious management there. And then our topic, pyloric stenosis. Right? Super simple thing. Dehydration and weight loss. Everything is fine with them except when they eat. And they don't get cyanosis when they eat. That's more like tracheoesophageal fistula or something. Here is just when they eat, the food comes back out because it can't pass into the duodenum. Super straightforward. And then the last table, food protein induced allergic proctitis. So I have a question right here that I had to annotate into there because I guess didn't really have anywhere else to put it. So this table, sorry, let me move up. So this question right here says, a 1-month-old boy is brought to the office for evaluation of blood-streaked stools. He was born at full term and has been breastfed exclusively. Great. He usually has 3 to 5 yellow seedy stools daily that have been bloody and loose over the past 3 days. That is not great. He nurses 2 to 3 hours but spits up a small amount of breast milk with every feed. So they're using the word spit, but gotta be careful here. His mother recently completed a course of antibiotics for mastitis, but otherwise has a regular diet and takes no medications. Weight, length, and head circumference have been tracking along the 40th percentile, which is fine. Vital signs are normal. He appears well. Physical exam shows diffuse eczema, and fecal occult blood test is positive, but we don't even need fecal occult blood test. We obviously know there's blood in it. What is the most likely cause of his condition? So although they use the word spit here, thinking of pediatric GERD is ridiculous here. There's no way, because GERD does not cause blood in the stools. Right? GERD at a really, really bad level, GERD could cause coughing of blood because of the damage at the end of the esophagus. Right? But even that would be with like some of the vomit may have blood in it, you know. But other than that, feces having blood is different, right? And the eczema here is going to be one of the helpful things to kind of make you think of milk protein allergy related stuff, right? So you would pick some answer choice that sounds like an allergic issue. And the correct answer here was food protein induced allergic proctocolitis. So procto anything is usually related to the anus, and colitis, right? So inflammation of the colon. While 20% of people chose mecyldiverticulum, another very common thing that does occur in infants, but not exactly what we would think of for this topic really, because mecyldiverticulum wouldn't be related to really just breastfed babies, and I don't know, we'll see the breakdown here, but mecyldiverticulum is very different and takes a little longer for symptoms to develop. They tell you in the explanation that breast milk contains fats, carbohydrates, and maternal diet-derived proteins from milk and soy. This patient has FPIP, IAP, likely from milk or soy, a condition exclusive to infants, right? So that's the milk protein allergy. A non-IgE mediated immunologic response to proteins in formula or breast milk causes rectal and colonic inflammation. The typical clinical presentation is a well-appearing infant with painless bloody stools during the first few months of life. Although some patients have associated reflux, most spit up in infants is physiologic. Right? Most of this, and they tell you here too that the physiologic response to GERD is spitting. So that's also the physiologic response to most of these other case scenarios where they're not really liking what they're eating. In pylori stenosis, the issue isn't that they're not liking what they're eating, but they realize that, you know, babies aren't dumb, right? So they're dumb, but they're not completely stupid. They can associate events that are happening. That's how quickly they learn. They realize conditioning events. So they'll learn that every time they eat, they vomit. So they're gonna stop eating, and you might try to feed them, and they'll just spit it out. And so the spitting thing is not specific to GERD, but if you see spitting and failure to thrive, right, and maybe even Sand-Differ syndrome related stuff, then you start thinking, okay, yeah, this is definitely GERD. Diagnosis of clinical, maternal dietary changes are going to help. Mothers can continue to breastfeed, but both dairy and soy should be avoided. Formula fed infants should be switched to hydrolyzed formula that contains pre-digested proteins. Patients should be reassured that prognosis is excellent and everything's going to be just fine. Mecyldiverticulum is where you have gastric tissue put somewhere else sometimes, right? And this can also have some painless hematochezia that's occurring just like this, but you know, stools are not typically loose. You're not going to get a diarrhea, right? They told you this, that the baby has loose stools, which basically means having diarrhea. And mecyldiverticulum doesn't cause diarrhea. It just causes bleeding and inflammation and other issues that we looked at back in step 1. And so that's what this table is showing you. Painless bloody stools, spitting up, and it's related to milk. So you get rid of that milk, or and try to give them milk that has already pre-digested proteins. Right? So here we have next topic, intussusception, right? A condition in which a portion of the bowel invaginates or telescopes into an adjacent segment. Right? Really weird, super strange kind of thing that can occur, and it's of course very painful. And also this harbors infection too, because if you imagine food is coming in this direction, it can go and then just come back down here and sit here. Right, so if food is sitting here, that's going to harbor infection, and then it can even lead to appendicitis. So that's a problem, right? This is really, really problematic, very annoying issue. Most common cause of bowel obstruction in children between 6 months and 3 years of age. Etiology is unclear in most kids. Risk factors include conditions with potential lead points, including mecyldiverticulum, intestinal lymphoma, submucosal hematoma in a child with henoch-Schindler purpura, polyps, and cystic fibrosis where the lead point is inspissated stool, right? Because they're going to have the stool that isn't moving, so the stool acts as a leading point to cause this kind of intussusception. Antecedent GI or upper respiratory infection is seen in many kids, which may cause formation of a lead point through the enlargement of the Peyer's patches in your ileum, right? So you can see this is the ileum because it's going into the large intestine. So a lot of things can be given in the question stem, in the beginning of the question stem, that you will somehow have to connect the dots to leading to mecyldiverticulum, because what they won't give you is this. This is a giveaway, right? Seeing the target sign, transabdominal ultrasound showing the target sign of intussusception. They're looking at the target from right here, and this is the direction they're looking in. So that's not going to be given. There's two targets. There's this target, and then there's this outer target that you're seeing. Right? So that's what you're seeing here. This one is inside the bigger one. Right? So that's kind of what you're seeing in the ultrasound. But that if they give you the ultrasound, then we have nothing to talk about. That's a very easy question. If they don't, then it's a little bit different. This here is the diagram telling you the full electrolyte understanding for pylori stenosis and vomiting in general. So make sure you understand what's happening here and how you're maintaining the metabolic alkalosis that vomiting causes, right? Your body has to respond and fix it, right? Intussusception table right here. They always describe this Quran jelly stool, which is basically stool that is very bloody looking and very thickish, right? Treatment is just air or saline enema. Right? You just have to do an enema from behind, from the anal hole, and then everything is gonna kind of come through and come out, and then of course do surgery to remove the lead point, right? So you can fix however this occurred, and it shouldn't occur again. Presentation will be with abrupt onset, super random, very acute, episodic abdominal pain in apparently healthy child, often accompanied by flexed knees and vomiting. The child may appear well between episodes if the intussusception is undone, released. The classic triad is severe abdominal pain, vomiting, and bloody mucus. This vomiting is initially non-bilious, but then it becomes bilious as the obstruction develops, because by this point you're way past the duodenum anyway. And you're going to see bloody Quran jelly stools and a very mucousy stool. On exam, look for abdominal tenderness, a positive fecal occult blood test or stool guaiac, palpable sausage-shaped right upper quadrant abdominal mass, and an empty right lower quadrant on palpation. This is called the dance sign. Right, so basically, because most of the things that were going to be on the left have kind of shifted to the right, because your ileum got pulled into the large intestine. So that's your dance sign. Ultrasonography is the best choice. Obviously, you're going to see the target sign in it. Ultrasound must be carried out during a painful episode to make sure you actually diagnose intussusception, not do the ultrasound at a point where it's been released, right? X-rays of the abdomen are often normal early in the disease, but later they may show a small bowel obstruction, perforation, or a soft tissue mass. Remember that SBO, small bowel obstruction, was a huge topic for CK GIT. So make sure you go back and revise that if you forgot what all that was about. Correct any volumeal electrolyte abnormalities, check the CBC for leukocytosis, for infection, and consider a nasogastric tube for decompression if necessary. In the setting of high clinical suspicion, perform an air insufflation enema without delay, as it is diagnostic and curative in the vast majority of patients, right? So air insufflation and enema, what it does is, let me see in case people haven't seen what an enema looks like. Yeah, I think there's a bunch of YouTube videos too, so you can definitely find it. Air insufflation enema. Oh wow, there's even pictures of air and air barium enemas to kind of see the telescoping that's occurring. But what I'm looking for, just look up the word enema then. So I guess this is a good picture. Here we go. This is what a typical enema looks like. You can buy this at the store, and you can fill it up with anything. And this is not the air enema, but this is an enema. Basically, you're supposed to put this in from behind, and then just squeeze it, and all the fluid that's in here will go into your rectum and enter your large intestine. Right, so it's a way that you can actually get patients to evacuate all their feces before the day of their colonoscopy, for example. Right, so that's one reason you would use an enema. Here, you would use the enema to actually squeeze in a lot of air and push this down. You're going to push this down basically by inflating it and push it back into where it was. That will then undo the intussusception and fix it. After which, doing an ultrasound may show you, or an x-ray may show you, where the lead points are that are causing intussusception to occur. And you can get rid of those lead points and then hope that intussusception doesn't occur again. And so that's what this air enema is all about. It does look like there's a bunch of YouTube videos of it too, so you can definitely go ahead and find one of those and watch that. Surgical resection is indicated if the child has peritoneal signs, which is definitely a problem. If the enema reduction is unsuccessful or a pathologic lead point is identified, which you should definitely get rid of. Insufflation enema is preferred over water or barium contrast enema for diagnosis and management of intussusception, as it is faster and carries a lower risk of complications. So this is the answer you pick. Right. Now, here's a question showing you how people can mess up. Right. So 40% chose intussusception. In my opinion, it was pretty obvious it's intussusception. But 30% of people fall for hemolytic anemia. So let's see how you could fall for hemolytic anemia. This is a question on a very high yield topic of Henoch-Schönlein purpura, a topic that gets tested a lot in many ways throughout the chapters, because this thing is related to many things. It's got renal disease, abdominal, even skin, and of course musculoskeletal. So it gets tested for many different organ systems. Here you have a 5-year-old boy brought to the emergency department for difficulty walking. He has had pain in his legs, right? So that's really strange, since the morning and wouldn't even get out of bed. He says that his son played 2 soccer games yesterday with no pain or trauma. 1 week ago, he had a low-grade fever. Okay, so one week ago, he had some kind of viral infection because it resolved, right? 1 week ago, he had low-grade fever and cough that resolved, so it was a viral infection. Review of systems is positive for non-pruritic rash on his back and legs for the past 2 days that the parents attribute to a new laundry detergent, but I don't think so. He has had no nausea, emesis, weight loss, or night sweats. Okay, he has no significant medical history. Vitals are showing low blood pressure. The pulse is fast. Physical exam shows an uncomfortable appearing boy lying in bed who cries with any attempt to move his legs. So he's got a lot of pain in his legs, right? So that's a type of arthralgia, and he's had a history of upper respiratory infection that resolved, and now he has a rash too. So if you see a young person with arthritis or arthralgia and a rash, that's Henoch-Schönlein purpura. That's exactly what basically is the mainstay of what this disease does. Moving on, they say a purplish non-blanching rash is noted over his buttocks and posterior thighs, which is exactly the location this rash develops in. Abdominal exam is soft with active bowel sounds, mild diffuse tenderness to palpation without rebound or guarding. Lower extremity joints demonstrate no deformity, erythema, swelling, or warmth. Right? He doesn't have anything weird like a bone infection, osteomyelitis, or Neisseria moving to the bone, none of that. He refuses to walk due to pain in his legs. He is admitted for further management. What complication of the underlying disease may he develop? So there's 2 big answer choices that can pop up here. It's either intussusception or renal disease. Right, and there's a lot you have to do for this kind of patient where this occurs, because there's a lot of complications, mainly the renal disease one. You need to be serially checking their urinalysis to make sure that the renal disease isn't getting worse, because it's very similar to IgA nephropathy. But here the answer was intussusception. People for some reason thought hemolytic anemia was related to this kid's issue, but it's not. Hemolytic anemia is not related to I'm not really sure what disease they were really even thinking of, where they would have hemolytic anemia with a rash and pain in the legs. No idea. I mean, whatever they were thinking of it and they picked it. But what you should be thinking of is Henoch-Schönlein purpura. Patients develop colicky abdominal pain due to bowel wall inflammation, prompting workup for GI complications, and you should be constantly doing workup for renal complications. So if you ever see an HSP topic, an HSP question, you want to make sure you grasp it as well as possible, because it's a very high yield topic. Right? And that's it for now. In our next session, we'll wrap up tomorrow morning malrotation of volvulus, meclodermaticulum, and the rest of these GIT issues, so we can be finished with that and move on to pediatric urology. So enjoy the rest of your evening, guys, and I'll see you all tomorrow.